So
Okay.
welcome everyone to our sixth best practices call. Can't believe it's 6 in a row at this point already, but we will continue these through June to allow for all of us to ride this first wave together. So thank you for coming if you're new to the call, and thank you for returning if you're back for a second call or more than as you know, these calls are designed to serve as an idea sharing platform, so challenges and solutions that each of you have developed in response to COVID-19. This is your call. So by all means, speak up if you have an idea or an issue you're experiencing you want to put forth to the team. Please let us know when you introduce yourself so that we can have all of these great minds provide some guidance on perhaps what they have done if they had encountered a similar issue previously. As always, immediately after the call, you'll get a brief survey to ask some questions about today's call and to prompt you to submit any ideas for a future call that you'd, any topics that you'd like us to discuss in a subsequent call. There's ongoing collaboration offline on the iMethods Healthcare Education website. So there you can add ideas to the idea forum, check out ideas that have been put into a blog thread related to solutions from our previous calls and suggestions from our previous attendees. And you can listen to any of the previously recorded sessions. So if you missed one or a colleague who wasn't able to attend might have missed one, you can check it out there. That link will go out with our regular Monday communications following this call. There's some great content in there. I'd suggest you check it out if you haven't had a chance to do so. A couple of housekeeping items regarding audio. So as always, we mute everyone coming in on entry. We'll unmute you, and then you can unmute yourself so that if there's any background noise that you're contending with on your end, you can account for that. By all means, we want to hear from you, so please don't be shy. When you speak up for the first time, please introduce yourself and let us know which health system you're with and share any data about your organization's current COVID status. So where you are in the surge, if you are experiencing a surge currently, that sort of thing. If you have a comment or a question during the call, please let us know who you are when you ask the question so Carrie can respond to you personally. And as I mentioned, the call is being recorded, so it will be available either later today or tomorrow on that healthcare education website. So without further ado, I will introduce today's moderator, our friend Carrie Ryan, who is Senior Director of Innovation at Tenet Healthcare. Carrie's held several relationships in her 20-plus year career in healthcare, including CNO and CNIO. She is passionate about leveraging technology to meet the operational and clinical challenges hospitals face to improve the delivery of healthcare. So we're very excited that she's joining us. She's had a lot of direct experience during the COVID crisis. She was instrumental in implementing their telemedicine solution, a consumer chatbot, and both employee and operational dashboards. So Carrie's got a lot of great intel to share with us. So I will hand it off to you. Carrie, thank you and welcome.
Thanks, Stephanie. I appreciate it. Good morning, everyone. Thanks for the introduction, and I look forward to some great conversation here. I've been on several of these calls over the last few weeks and just really enjoy the takeaways. I shared with Jason last week that I don't think there's been a call that I've been on that I haven't taken something tangible away to say, hey, how can we look at this, or just a new idea to think about, something to look at. So I appreciate this collaboration, and hopefully today you guys will be able to take something away. Let's see, let's just jump right in. I think that we've sent out a couple of topics here, and the first one, I know that I think it was the very first call we started talking about, what are the things that we're having to look at around COVID that we haven't had to before, and many of us have implemented new solutions. I have to say the telemedicine solution that we implemented in about 10 days was a brand new solution for Tenet, or at least a new use case with a new vendor. So, but I wanted to talk a little bit today maybe about leveraging existing technologies. Like, what are the challenges that clinical and operations teams are experiencing, and how you all have been able to leverage technologies that you have either in a different way or expanded capabilities. We've all, I think, been in situations, and you certainly see this as a hot topic on LinkedIn with just, many emails about, hey, we have a COVID solution, we have this. And it's really hard to take brand new technologies and implement them when we don't know, one, how long those technologies are going to be valuable, how long it's going to take to implement. And so looking at what you have and being able to either expand its use or expand the use cases, I think is very important. So let me start with just one that we've looked at. It seems like kind of a basic thing, but we don't have communication and collaboration systems across all 64 of our hospitals. We have a few out there. We don't have a standard. And we just have been implementing Office 365 with Microsoft Teams. And so we've been looking at how different ways that we can leverage Microsoft Teams in communication and collaboration during the crisis, but then, it's something that's sustainable long term for things like family and patient communication, staff rounds, even something as simple as being able to round using a team technology, being able to do dashboards via a collaboration tool like Teams. So those are, there's lots of different things you can do with it, but rather than implementing something new and different, we're trying to figure out how we take an investment we already have in a time when we don't have a lot of money to leverage that. So I'd love to hear what you all are doing in this space. Anybody want to jump in?
Hello, this is Julie Derringer from Baptist in Pensacola. I'd be happy to jump in. I don't know that I'm going to give any big aha moments, but I'm happy to share what we're doing. We already have Zoom. We already had a business arrangement with Zoom. Our mental health had already started using that from a telehealth standpoint. We expanded that very quickly. I know a lot of hospitals across the country have started to do that, and we may look at a more long-term solution, but right now Zoom seems to be working well. But we're also using that for patient communications and visitations. So we created a team to work with our patients and with their families, since they cannot visit them in the hospital. We made sure that we had a place within our EMR system so that they could document that collaboration and that visitation as well. We also had some additional places for documentation that we normally are some people with from ancillary departments that normally might not touch our EMR, whether they're in disparate systems or whatnot. We did create places for them so that when we do run an exposure report, their names pull into that in case that patient is found positive or is a patient under suspicion. Similar to what you mentioned, we also started in December implementing Office 365 and Teams, and that concluded January, February. So we've all started to use Teams more and more, although there are some of us that still have the professional or the licensed Zoom accounts. Power BI, we've had Power BI for a time. We're moving to the professional version, but with our current version, we've got our COVID summary dashboard. We're getting ready to launch our inpatient dashboards to track, our vent usages and isolations and testings and things like that. Telmetic is what we use for secure health messaging. So that's become an integral part. I think this has definitely helped to adopt that, because we have, I don't know the official number, I probably should. I think we have about 1,200 people working remotely right now. And of course, they need to be able to call out without it showing where they're calling from. So they're using that technology of Telmetic to be able to call out to patients in its same Baptist hospital. And also being able to message each other. And then our safety huddle, we do a safety huddle every day from an acute care perspective, not from a clinic perspective. And it brings together the majority of the departments within the hospital. We've leveraged Zoom for that, as well as our Office 365. So, and it's gotten real tight, that process has, to be able to go in, record your own attendance on that, and the agendas that we have. So those are some of the pieces of technology. I'm not sure if that's exactly what you're looking for.
Perfect.
That we were able to leverage.
That's great. Thanks, Julie. That was a great list. Yeah, so the safety huddles was something that we've been looking at for the Office 365 teams, where you can do it asynchronous as well as synchronous. Power BI was a great one. Definitely, hopefully, a lot of people who have that have been able to leverage that for reporting and dashboard usage. So yeah, that was exactly perfect. Great information. Thank you for sharing.
Hey, Carrie, it's Mike Carr. How are you?
Hey, Mike. Good. Good to hear your voice.
You too. Long time. Couple
Yeah.
things we did at Baptist, not really related to patient care indirectly, but the security for health systems has been a big concern for everybody because all of the bad guys are taking advantage of the situation to attack hospitals and everything else. So we actually implemented a multi-factor solution, which is everybody's seen it with your bank. You have to get a PIN, et cetera. We rolled out some mobile applications to all the physicians. So anybody entering hospital network has to be two-factor authenticated, which has really tightened up the security for the hospital. So from a security perspective, that makes the security guys sleep a little better at night. And I'm doing a lot of mobile stuff with them. So the other thing we did too, I think I mentioned this last time, I don't know if you're on, but we've actually rolled out Dragon Mobile Mic to all the physicians. So since a lot of them are not on site working remote doing telemedicine, they're able to do their dictation without being at the hospital, having a mic in front of them at a PC, and also, even if they're in the hospital, not sharing, touching a mic, et cetera. So those are just a couple of the technology things we've kind of had in the works, but forced those through pretty quickly to, with the COVID stuff. So it's
Great.
helped us.
Thank you for sharing. Yeah,
Sure.
Can you talk a little bit about a little bit more about the security and multi-factor? I mean, for most of us on this call certainly understand the implications of that security component. What I'm thinking about it from the perspective of provider adoption and their willingness, like most of the, as we've been rolling out even some of the telemedicine things, having them with their own devices, having to add additional layers of security, you run into some pushback. So I'm just curious if you guys had any of that and how you guys overcame that.
Yeah, we've been doing, I don't go into too much depth. We can also chat later if you want to, but one thing we've done is we've done our own app store for internal to the hospital. So we roll out applications and have our own app store, and we can secure those. And what we've done basically is created a partition, if you will, on, this is all for BYOD, all users' private devices. We create a partition on there that is secure. And we can wipe if their phone gets compromised or their iPad gets compromised, but the rest of their phone is still, we don't look at their pictures or their personal email or anything else. We keep everything kind of isolated in a container, and then we roll out applications into that container so they get the right versions, they get the right application, and we can track who's doing what. From a multi-factor perspective, to answer your question, so we actually have a mobile app that they can actually punch in, and they can get a PIN without having to have a cellular or a Wi-Fi connection. So if they're in a basement or they're somewhere where they don't have a Wi-Fi connection and they need a two-factor in, there's an application they can just tap on it and the PIN comes up without any need to be connected. So we rolled a multi-factor out to, there's about 1,800 physician, combination of employed and unemployed. So we rolled all that out, and we got basically no pushback on it at all. I mean, they all were okay doing that. So basically all employees, all non-employed docs, and everybody, we've got a few vendors we're still working with, but so they can't get into the system. We can track when they're coming in and everything else. So it's an audit mechanism too, to see who's entering the system. So if we start getting attacks from the bad guys, we can kind of tell what's going on. And there's some other tracking we can do with them too, as far as a geo tracking on where they're at. So if they try to log in from, Orlando, and then 2 minutes later they're trying to log in from Chicago, we can track some of that stuff. So there's a whole bunch of stuff in there. But yeah, we've started rolling out all the mobile stuff. In fact, that's what I do. I'm in charge of the mobile security program. So yeah, if you want to chat more about that later, I'm happy to.
Great. Thanks for sharing that, Mike.
Thank you.
Good stuff. Anyone else on the leveraging existing investments? Anybody else want to share? Nope. All right. Well, we can always go back if somebody comes up and wants to share something or thinks of something that would be beneficial for others to hear. So we'll move on to the second topic, which is business continuity planning. We probably had a little bit of conversation around this in almost every call. And, I think we continue to learn as we go through this. I hate to use the old analogy, but it's almost like peeling the onion, that you think about the high priority items that maybe weren't in place, you thought you had in place, and then each day or each week something else pops up that would make the business continuity plan better. I personally have not been heavily involved in this. On the tenant side, we do have a regular daily planning call where one of our IT VPs is designated as the person to sit in on those command center calls around business continuity, and then she reports back to us what's happening in that space. A lot of it, IT has been heavily involved in that, I can say, and I think one of the things that would be interesting to hear from everybody here is, to what extent have you or your IT team been involved in the organizational business continuity planning? And if you think that changes, going forward need to be made based on either involvement, less or more, by IT in the future. I'm interested to hear what you all have to share on this topic. Or is everybody just burnt out talking about business continuity?
Hey, this is Julie from Pensacola.
Yes, Julie.
We've started looking at, we started a task force a couple of weeks ago to start to look at what does the world look like post COVID and how to continue on. I think we've learned a lot from what we have found so far, because our first piece of the puzzle was what all needs to be rescheduled, right? What all had been canceled, what all is pending reschedule. We were able, from a physician enterprise standpoint, to see a lot of patients on telehealth, but not all. So that has been part of that. You would be surprised from our clinics, or maybe you wouldn't be, the type of lists that we've received from them. For some reason, they stopped any normal procedures, like to put in requests for surgeries, for instance, and just started holding that into, I'm not kidding, a Word document list. So we had a lot of different lists that different people were keeping and working to mesh that. Luckily, at the very beginning, we had created a cancellation reason specifically to COVID. We had created reports for that. So we've only needed to do some minor tweaking to find some of that information, understanding that there's going to be room for error, but identifying what that backlog looks like. We've been looking at how do we, a lot of things from the government that they've given us for guidelines. Can we put some people maybe off-site out of the hospital into standalone surgery centers for some of our elective surgeries? How are we going to be able to do the testing for those people? Of course, we have a PPE task force, because we could go ahead and open things up, but do we have enough PPE for that, as well as to take care of our patients and our coworkers, healthcare workers? So there's been a lot of business planning around that continuity. We're still learning more and more. And I haven't probably looked in the last 72 hours to see what new has come out from the government as far as guidelines, but we're certainly watching that close, many groups of people within our organization.
Thank you, Julie. Thank you. I think those are all things that in some capacity everybody's having to deal with, and I guess, like you said, I'm not sure that I'm surprised, but we all go, well, why did you do that? Why would you stop a normal procedure and go to paper, Word document if you didn't have to? But I think that in these crisis situations, people a lot of times they revert to what they know, and that is just, I need it all on paper just in case, or I don't know what's going to happen if I put all those requests in and we don't fulfill them for 2 months. What happens? But I'm sure there's other processes that are similar to that have reverted to old ways during the process. So thanks for bringing that up. Anyone else? I think it's interesting on the business continuity, especially around surgeries. Those who don't work in ORs or are not clinically familiar with the way an OR works from an operations perspective, it's, well, why can't you just start surgery back up? And it's, as you mentioned, there's equipment issues, there's supply chain issues, there's staffing issues. In many cases, OR staff were furloughed, and getting them back faster than maybe they had anticipated, and making sure you have enough staff on hand, getting patients rescheduled. Patients are I'm sure there's some areas of the country where patients are jumping to get back to their scheduled surgery, and other places where they're just afraid to go into any kind of medical clinic or hospital. So that's another issue, is understanding the operational impact of ramping back up. Although we want to do it as quickly as we can, it's got to be efficient and safe.
And this is Laura Williams from UK. I'd kind of say we're seeing some of those same things. Yeah, sorry, I missed last week and I'm late today. Because you got meetings. But I think what's interesting to me right now is that we're seeing the change, what was urgent, get ready for the influx. We need the alerts, the banners, the drive-throughs, that was such a crisis mode. And then it got quiet for about a half of a week, maybe a week. It slowed down a little. And now it's ramping up with this new, how do we reopen? And we just got off a meeting with the drive-through people, because we're using our drive-through now to facilitate the pre-procedure testing. So we can do COVID screening before they come in for procedures or surgeries, right? And so it's kind of strange to see that we were protecting and getting ready for this surge and this wave, and now it's empty. And now how do we leverage to convince people to come back in and to use some of our same pathways to keep folks safe? And I think all of the things we were doing before, the making our own PPE and doing the telehealth, and that is, I'll be curious to see how that affects getting people into the buildings, because I do think there is fear among a lot of patients. And I think I think the person talking before had said that they think it'll be, some folks might be afraid to come in, but others might be lining up. And we're all kind of holding our breath right now to see what's going to happen. So but it's definitely a big shift in work.
Yeah, and Laura, I'm curious, because at Tenet, this is Carrie from Tenet. So we have both ambulatory surgery centers and the acute care. The ambulatory surgery center is not as big of an issue for patients coming back because it's a standalone facility. They're not worried about being co-mingled with COVID positive patients. Hospital patients, on the other hand, I'm just curious about, and I haven't had this conversation with any of my clinical leaders, but how do you drive the throughput of those patients and the communication to the families of, You're not cohorting in areas where COVID positive patients are, or here's what we're doing to maintain that separation for you for safety, whatever those conversations are that guide patients to the comfort level of, okay, I'm ready to go into a hospital and have surgery.
Yeah, I'll be honest, I'm not sure exactly all the things that UK is doing, because that's more on a marketing side,
Sure.
and I'm drowning under the IT stuff.
Yeah.
But
Yeah.
but I do think there's a component of that, and there is very much an advertisement that has to happen that says we're safe, we've got you covered, we're here for you, we're here to keep you safe. I'm already seeing it in some of the communications that go out. Is that we're going to have to do a little bit of mental sales pitching, right?
Yeah, for sure.
And it's so weird to have flipped in the course of a month and a half from, oh my gosh, oh my gosh, oh my gosh, to, okay, hurry up and get people back, and not being not knowing how to do that.
Hey, Laura, this is Clint Drolly. I have a quick question and then a comment. The question is around the drive-through testing. I love using, that existing model for that. The question is around timing. So what is your current response, time for the testing? So if they're going to do elective surgery, they go do the, the drive-up testing. When do you get results there?
Our tests are usually done within 12 to 24 hours. We have our own testing on site, and so that helps a lot. Every now and then it might go past 24, but they're thinking if they're testing probably 2 days or because day prior might be cutting it short, right? And so
Right.
I think they're looking at potentially doing that 2 days prior, and then that day prior they're able to talk to them and say, yep, you're clear, here's your instructions, and come on.
Gotcha. So you're processing your own, it's just faster. Okay. And I know that's different kind of at every facility, how quick the rapid turnaround is. But the comment, Carrie, go ahead.
Oh, I was going to say, we would love to have the rapid test. I think we were only able to get like 20 or 30 kits of them. They're just not available here right now.
Yeah.
And we've had to convert to they have come up with a way to use oropharyngeal swabs instead of the nasopharyngeal, because we are in a drought of the NP swabs right now. So they have worked up a way with our own testing that we can do oropharyngeal, and we have thousands and thousands and thousands of those. So we've had to be creative, and it has been the testing has been a very limiting factor.
Yeah, I think that's for sure. Speaking about, that's one of the biggest obstacles that many, health systems are facing. There's a select few that are, have the rapid testing, of course, and that they're doing it really quickly and they have plenty of capacity, but that's definitely not what I'm seeing as the norm. There's my comment was around the communication. I'm sure every health system has a robust communication. Baptist in Jacksonville, it's this multi-channel strategy that's definitely being employed already, and it's a combination of kind of corporate driven and then also physician and office group driven communication. But creating those pathways and the education and that whole idea of trusting the healthcare system, and they're using a lot of data, and facts to dispel fear, of course, and that kind of thing. But that's a huge part of this right now, is this reentry of getting people comfortable, right? So it's interesting, again, like you were talking about the transition week over week, is now you're seeing news report after news report from everybody that physicians are so concerned that people aren't even coming in with heart attack symptoms and strokes and all this stuff because they're so scared to come back because they don't think it's safe, which is not. That's not, I mean, at least I can speak to our quality metrics in North Florida again. Like, they're the best they've ever been. It was like, we have the least amount of hospital-acquired infections and COVID possible that I've seen in years, right? So the data about the safety of the hospital, especially at this point with all the protocols, is better than ever. So that word's got to get out, and that's what's being pushed, I know, from every channel possible to make sure people get that it's safe.
Yeah, and it's a full-on marketing campaign, like even in the media, truly TV advertisements, things like that.
Yeah.
Because it is, you have to get this message out in every possible way.
So I have a question off of that one. So we've been talking about sort of the requests coming in from the clinical teams in terms of, as you said, new flags in the EMR and changes to documentation and things that were urgent. Now shifting a little bit to some of the IT projects, I know I'll speak for Tenet, we, immediately stopped all projects that were in flight, reevaluated, cut the budget, and reforecasted. And then to your point, Laura, as soon as we finish that reforecast, okay, now figure out what you're going to start. Right? So you stopped everything, reforecasted, now figure out how to get started back up. And without, knowing what your resources are, which resources have been furloughed, which resources from the clinical side are available or not available, what projects can we do without impacting hospital, needing to pull hospital resources to do them, clinical resources, which is, never the best way to do a project without having your resources that are pertinent to the outcome of the project. But now we're reforecasting to what do we ramp back up, and how do we do that? So I'm interested in hearing what you all have, going on in that same space. I mean, literally it was a matter of one day we stopped, finished the reforecasting, and the next day it was, okay, now let's figure out how to get ramped back up.
Well, this is Laura from UK again. I will say that is my current nightmare. It has been a challenge because I think we have most facilities, unless you're on the over busy side, most of us have lost revenue and are dealing with significant budget shortages. And it is definitely affecting us. UK, I think, publicly in the newspaper, they furloughed 1,500 people. I know our IT department is we're each doing like a 2-week furlough staggered so we can keep the business going. But we still have to find ways to cut budgets. We've lost consultants. So not only do you have the COVID work, which it's not as urgent, crazy, but some of it is, like the support to get those procedures done. We're doing a lot more work that's still COVID related and trying to open up all these projects. For us, we never really stopped a lot of them. We're just crazy like that. And we've got, we're working on our conversion to Epic. So that can't stop. That team has been very protected so we can stay on timelines. But even on our own legacy side, we've been doing a lot of projects and a lot of work. And it is a challenge when you're missing the resources. Maybe the person to do the design is here, but not the person who needs to build,
right,
or not the interface expert who needs to build and map things. And so our PMs are struggling. It is the current work of this week and some of last week. And we're having to ask, okay, who's going to be here this week? Who do we have? Who do we need? Can you get a substitute? And it's very difficult. I don't know that I have an answer. I'm just going to tell you we're experiencing the same thing, and it's very hard.
Yeah, well, I think it's nice to always, know that we're all in the same boat. I wish there was an easy answer, but it's a logistics nightmare of
Yes.
any given project that doesn't need, the small ones are the easy ones. It's the major projects that the hospital, if you're in a single hospital system or a multi-hospital system, they're needing it. They still want it. It's still part of their business plan. And they built into their budgets for some of these changes to be made. And yet, when we had to do furloughs, not necessarily were you able to pick and choose who was going to be furloughed based on this or that project. So it's difficult logistically. Anybody else have anything they want to share on that and what they're experiencing in their facility or markets?
Are other people going through that, or is it just the two of us?
Laura, I guess you and I are in the same boat.
Sorry, I was double muted. This is Julie from Baptist. No, I really think we're all in the same boat that way. We all want to get business back on track. We want to bring everybody back in. But we do have to balance that. We have concerns. What if we start opening things up and not so much that we get another high, another surge, but I think for us, it's our supply chain that's one of our biggest worries. What do we do when we don't have the PPE there? So we can't see the patients that need to come in. Supply chain again, how do we test the people that need to be tested? When do we test them? To make sure that, when we can start back at full capacity, that all of our slots are full. Do we test a few days, 3 days ahead to make sure we're getting those tests back? How do we test our healthcare workers? There's a lot of unknowns right now. I think we've got the right people in the room to discuss those and to make those decisions. But I definitely think, and I'm in the same lines as you all, and even our CIO thought, we thought maybe there would be just a short time where we've ramped up and we've gotten everything ready for a surge, and now we can wait to plan to open everything back up. That's definitely not the case. We're going from one meeting right into the other. But it's definitely a balance, and the next 10 days are going to tell us a lot.
Julie, I think you make a good point. I think that, every day things change in this environment right now, but I think as we start to see facilities ramp back up, and here in Florida, we know Monday's sort of that day when things are going to start picking back up. It's going to be that 10-day mark when we, know whether or not we're able to hit that phase 2, as they call it, or, really continue to ramp up, or do we have to back up a little bit? And I think everybody's afraid to go too far forward to have to back up more. So it's all in the, I think from an IT perspective, just like any project, it's all in the planning phase, right? We don't want to plan out a project to get started back up and then start it in 3 or 4 weeks, realizing we don't have the resources to back on site, or, most of our resources at Tenet are remote anyway. So, but do we even have the resources we need to start that project? And we don't want to start and stop again, because that costs us more money than it does to just wait it out.
Right.
So, yeah, thanks for your thoughts.
It's Stephanie, sorry. Real quick question. As you guys are anticipating things opening up, both at the state level and perhaps in the hospitals, has there been any preliminary outreach to start scheduling those patients in any sort of fashion, or how are you prioritizing those? I know Todd Yucht at Virginia Mason last week was sharing that although they hadn't completely released the ban, that they were starting to do some scheduling a bit far out in anticipation of having that open up. What does your scheduling look like at this stage, if at all?
This is Carrie.
This is
I'm
Laura
not
from
involved,
UK.
so I can't answer. Yeah, go ahead, Laura.
Well, I was going to say, I don't, it's kind of like I said before, you're stuck in the IT world and you get pieces of the details. But I heard in one of our meetings today that there is actually an oncology review board that is looking at the surgical cases. And so part of our drive-through testing for those pre-op cases is they have to be cleared by that oncology review board as, this is one that meets the criteria. So I think we're looking at who do we bring in? What are the right things as we're beginning to ease in? It's not like we're opening wide open, but we're where they had mandates about what elective procedures, and there are different tiers. I think we are starting to work our way through the tiers and letting those be our first and most important people.
Sure.
And to the point of other people saying we're worried, we're going to have to ramp up a little bit and watch our PPE, ramp up a little bit and watch the staffing, and that's, I think we're obviously taking measures to do that with the best clinical judgment we can.
Great, thank you.
Okay, well, just doing a time check here. What are we at? 40 till 20 till. This one I know, Julie, I think you already mentioned this one, and I think that one of the areas that immediately, I think it was the first phone call I got was, we need a dashboard to be able to manage the data that's coming in, because it's all manual at this point, right? To determine the number of events we had available, number of positive patients versus those that were under investigation. And you could pull them from multiple different areas, but most of it was still manual and having to be done by the admin supervisors in huddles in the mornings. And then the next request came around our employees who were experiencing symptoms and needed to be quarantined. And we have several of our hospitals that their employee health is really still on paper. They don't have a robust employee health technology system, and so they were losing track immediately of how many employees were quarantined and when they were scheduled to be back to work. And just like workers' comp, if you have them out of work for 21 days instead of 14 days, then we're losing money. We're losing, resources that we needed available. So we put together an employee dashboard that employee health and the employee logs in and puts in their symptoms, and then employee health reviews those symptoms and maintains the date that they can return to work based on their symptoms. So, if they don't have symptoms but they were exposed, they might be out for 14 days, and then all of a sudden they start experiencing symptoms. Then we put them out, based on that. But we were able to put together a dashboard that is at the local market as well as the corporate level. So infection prevention and our employee health nurses could manage that. And there's certainly systems out there that do that, but we were able to pull together the employee dashboard in a matter of about 3 days. And so it was faster for us to do. And our employee health nurses have actually asked if we can make some modifications to it for them to be able to use long-term for other employee health purposes. So that's a good thing. That's something that we've been able to put in place, use our current systems that we have for analytics, and then be able to potentially leverage it longer term without having to purchase a new database. What have you guys, I know, I think Laura, it was you that mentioned about the BI tools, Power BI. Anybody else using anything that they've had to do around dashboards or for the state reporting that needs to get done? Any innovative ideas around those?
Yeah, this is Laura from UK. I know we've got several of our own Tableau dashboards that our BI team, our actual business intelligence team, put together. And it was a bit of a challenge trying to track. We've got surveys going out actually for all employees, kind of what you were talking about with employee tracking. Every employee before they come to work is supposed to complete a survey, and then they have to scan proof that they've done their survey before they walk in the door. And if not, they're stopped for screening at the door. So it's we're tracking all of our employees and their symptoms, and they've got that working. And then we've got the dashboards for the actual testing, and that's been a challenge because we're getting admissions from other facilities or referrals where people might have been tested elsewhere. So we're waiting on someone else's tests, or we're getting positive results from a different facility. And so that just brings up data challenges. And how do you make sure all of those are captured in your dashboard? So we're doing them, most of them through Tableau and our own personal reports. We are sending things to the state. We're actually working with our whole city area to help manage things for other facilities as well. So we've had to incorporate lots of external information.
Thanks, Laura. Anyone else? I know I've heard in multiple different occasions that there's some pretty innovative things happening around data, just because it was, we couldn't manage this crisis without data on a almost a minute by minute basis. So I'd love to hear if there's anyone else on the phone that wants to share what they've done. Don't think anything's too small. Whatever you're doing is benefiting your facilities. Nope.
Hey, Carrie, this is Trip. Quick question.
Yeah.
Maybe I missed it. You were talking about the employee dashboard. What technology is that in? Did you have to go out and purchase something to get that done, or did you use what you had?
We use what we had. We actually are using SharePoint. It's what a lot of people would consider a rudimentary system, but again, it was a quick turnaround. And then we use Power BI in the background to pull the data into a dashboard. So we use SharePoint. Employees, they get an email every day with the link, and they go into the link and they enter their symptoms. It pulls that into what the employee health information that they put in. It's all locked down by security. So if Carrie Ryan goes in and enters my symptoms, only Carrie Ryan can see my symptoms, except for the employee health nurses. And then it's pulled into a dashboard that's married up with, it's a basically 2-tab dashboard. One has all the patient information, and then one has all the employee information for executive view.
Great, that's helpful. Yeah, we're seeing that too. Is using what tools you have. And some people, yeah, some people are having to go out and buy new things, but
yeah, it was. We were actually looking at a system. As a matter of fact, I think I heard about it on our very first call here, and I had my CNO on the call. We got off, and she texted me and said, "Can't we do something ourselves fast?" And I got our analytics team on the phone, and by that afternoon, we had a prototype and implemented it 3 days later. So it was pretty darn quick. And again, it didn't have to be anything fancy. They just needed the information. So nothing too small. Quick was better.
Agreed. I think that's why ours is just in Tableau, rock and roll.
Yeah, exactly. I mean, for those who know how to use it, they can build things pretty quickly for us. It's just a matter of asking. And then, we had every employee health nurse across our system on a phone call, walked them through it, talked to them. We met every other day for a week to tweak it to their needs, and now they're off and running. So nothing fancy, just get it done. So I know, Stephanie, we're down to 10 minutes. I'd like to, I don't know if anybody has any preference on the last 2 items, but I was thinking we would focus a little bit on maybe not necessarily just AI, but lessons learned out of all this, not just from a business continuity perspective, but I know from a hospital operations perspective. I've already started having conversations with our CNO and others about, what was missing in their day-to-day operations that would have made this crisis easier to manage, not just at a corporate level, but at a local level. And one of the first things she said to me was AI tools. We've looked at several over the last year, and it just had not yet bubbled to the top like most of the technologies we've seen implemented during COVID. For whatever reason, we realized in a crisis that there was technology we needed, but in a non-crisis mode, the investment seemed too big. But the ability to better see what was happening with our ORs and get a handle on those changes in volumes. And then now, as we're building back up, I think that AI tools would be extremely beneficial. And I'd love to hear anybody who maybe has those tools in place that they found that, gosh, if we hadn't had those tools in place, we wouldn't have been able to manage as well as we did, or any lessons learned that you guys are coming out of it from a change in your technology strategy based on lessons out of this crisis.
Carrie, hey, it's Steph. To build on that, I think it would be interesting to hear also, based on lessons learned and technologies that have been implemented for this, what are the keepers? Sort of what is going to be the going forward strategy as part of our new normal, right? As we move to that last bullet point, but what parts, what you've done have either the ability to morph into a longer term strategy or now have become so integral into your operations that you couldn't see going backwards.
Great. Thanks, Steph.
This is Julie from Pensacola. I'm going to have to drop here in just a minute. The one thing I'll add to the new normal is there's a lot of considerations about who can work remote. There's a lot of changes when it comes to the new normal, how we care for patients. You know, telehealth has become a part of that, although they're going to lift some of those restrictions. But I think that from a hospital employee level, the remote work is definitely going to change the new normal.
I know you need to drop it. Are you referring to like, okay, we can use a smaller footprint in offices if these specific employees just remain remote? Or is that what you're thinking? We put everybody remote who actually needs to come back into the facilities?
Correct. That's exactly it. Not necessarily removing the number of employees that we have. You know, we still have work that needs to be done. You know, it's been very hard, I think, for an organization such as a health system that doesn't normally have remote employees. I've worked for companies remotely. And it's a much different thought process and approach to HR. So that's changing, I believe. You know, who can work remote, because building out office space is also an investment, and it is an investment we need to take on when we can see how productive people can be working from home.
Great, good point. Thank you. And thanks for all your input today, Julie. I appreciate you being on.
Well, and let me return that. Thank you guys for having these great calls. I really appreciate it. I'm sorry I have to drop, but y'all have a great weekend.
You too.
You too.
Anyone else want to share about their new normal, what things that they either need to find and invest in, or that, you know, we need to take with us into the new normal? Love to hear some other thoughts.
Hey, Carrie, it's Clint. I don't have an answer. I just have a question along those lines. You know, there's been a lot of talk about, you know, the waiting rooms. You know, are waiting rooms going to be a thing of the past? Is everything going to be virtual check-in? That's a new normal that, you know, we didn't really anticipate that waiting rooms will be no more.
Interesting thought. Yeah. I haven't heard any conversation about that yet, but then again, I'm not in a facility, so I'm going to keep my ears open for that one, though. It'll be interesting in our outpatient clinics, like how that changes the environment.
Yeah, this is Laura from UK. I think some of those things will become and stay the new normal. You know, we already have a lot of clinics who are doing like your waiting room is your car, and they call you when it's time to come in. And I think because until there's a vaccine or some confidence about how COVID's going to be, you know, responding in the future, I think those things will probably become the new normal. I don't know for how long, if it'll just be the next year. Something that UK I just read about that we did that I thought was kind of awesome is they set up our Coumadin clinic, set up drive-through testing, because we've got people who just need to come in for those routine, you know, INRs. And that's kind of a brilliant, and the patient's response was, can we keep doing this? Because many of them are elderly and it's hard for them to get in and out of cars just to come in. So I think a lot of these things, the public is going to want them to stay. I like telehealth. Saves me the road trip, you know. I do think we will see a very different healthcare environment in the next 10 years because of this.
This is Mike Carr. I wonder how the physician, their workflows and everything else is going to change for the physicians too, instead of waiting and keeping people in waiting rooms for an hour to wait to see them. If they're doing televisits, you know, are they going to have to be on time? Are they going to have to manage their schedule? So I'm just wondering what the physician behavior is going to be like going forward, especially for the primary care providers.
Hey, this is Eric Ammons. Actually speaking to that about the remote. So I'm here with Baptist Health, and Jacksonville. And one of the things I wanted to say about that, one of my responsibilities in the organization now is actually working on our restart recovery plan as we come out of our peak and start to see the decline or the flattening of the curve. And part of that is part of my initiative. Actually, one of my actions was to actually remove all of our non-essential personnel to remote as we start this process. And now on the back end is how do we shape ourselves for the new normal. And that's kind of how I've been positioning with our executives too, is that coming out of this is there is going to be a new normal. It is not going to be business as usual prior to this for us. And so even talking about remote workers, some of the conversations I've had, even with some of our contact center type of staff directors and executives, is that they've moved all these folks to remote and they're monitoring their productivity. And if they see that their productivity is the same as it was if they were sitting in the physical office space, and they're still maintaining high levels of productivity, that will be perhaps the new norm for them. And so it does change the landscape of how we actually work. And for us, from an IT perspective, that means that we have to still now even do more around making sure we monitor and manage our capacity for our infrastructure to support this new norm, right? You're now talking about sending folks home with Meraki devices to be able to connect into the office to sit into a contact queue for calling queue, right? And how do they do that in these virtual spaces that they're not in the same office location where you can see the queue board to see what calls are coming in versus what are being answered in the time in queue and that type of stuff. How do you manage that? That is it's a new complexity that we have to kind of consider. But I think that we're going to come out of this realizing that, for one, you can't bring everybody back into the office at the same time because you won't be able to maintain the physical distance requirements. Again, someone mentioned about the PPE inventory and making sure you have enough. Well, that's another consideration you have to account for. And just having just basic sanitation, the hand sanitation stuff to keep your hands clean and those type things around the office as an inventory, that's another thing to have to consider. So I think when we come out of this, one of the things that I think is beautiful for us at Baptist, at least from an IS perspective, we've already started before this with doing a lot of staffing where we were doing remote staffing, where we had people that were already 100% working remote for us. They weren't sitting in our physical location. They were probably working from home. And we've moved some people to those kind of configurations. This, to us, I think is going to be just an expansion of what we already had started. So I think we were kind of ahead of the curveball from that perspective. And I think that's going to be the challenge for everyone as we come out of this is how do we go back to doing the same level of business productivity in a new normal configuration, right, for our staff? How do we as managers and leaders manage our staff in this configuration? I happen to be fortunate and I think I'm a little lucky is that in previous work experiences where I've managed staff, I've done that already. So it's comfortable for me. But there are a lot of managers and people who've never done that. They've actually had all of these people working in the office. So we have to look at all of those things, and those are factors that we're looking at now, and how do we support the operations from a clinical perspective when we're doing all of these changes to our environment. You know, the governor's now lifting the ban on the elective surgeries. Well, that means how do we go back to doing scheduling those appointments, and how do we support that? How do those people work still remotely? So there are a lot of factors around this, where we are now versus how do we go back to our future new norm. And I think that that's going to be very interesting how we come out of this in what the new normal state is. You know, it's a little challenging, I think, for me personally speaking. I think a lot of you maybe on the call can say the same thing. My wife is a school teacher, and I have 2 children that are in in elementary, high school. And so I'm sitting here at home. I work crazy hours remotely. My wife is now teaching school remotely here in the house, virtual, and I have 2 students that are taking virtual school. So how do we manage and even have a staff that even manages that? Because everybody's dealing with some sort of dynamic that they have to do that under, right? And so how do we do that and not overwhelm our staff, but still maintain the level of productivity that we have to maintain? So I just wanted to kind of bring that up, that we're looking at those factors, and we're really kind of considering that now, and we're working through that to provide information to our executive leadership team within Baptist.
Thank you so much. That was a lot of great information, and appreciate you sharing your transition experience. And I'd love to hear some more about that as we go forward in the weeks to come.
Sure.
Thank you. Great. Well, Stephanie, I know we're at the top of the hour.
Thank you, Carrie, so much for moderating today's call. Thanks, everyone, for the robust discussion. Lots of great ideas and great information shared. So really appreciate you jumping in and sharing stories about what is happening at your respective health systems and how you're managing this rapid transition in and out of the surge. As we will do again next Thursday at 11 a.m., we will have our best practices call again. You'll get a survey immediately following this call to get some feedback about today, but also to submit ideas. So a lot of stuff covered today. I'm sure it's got many people's wheels turning. So if you've got some ideas that you'd like to have us discuss on next week or subsequent calls discussion, please go ahead and submit those so we're able to include them. And then by all means, share this invitation with colleagues who you feel would benefit from it. You know, the more the merrier, the more voices we have, the more perspectives we have, the more valuable these best practices calls can become. So with that, I thank all of you for joining us and hope to see you again next week.
Thank you all. Appreciate participation.
Thank you.
Thank you. Appreciate it.